Good afternoon. My name is Blaine Robin. I'm a senior lecturer at Leeds Beckett University in England, and I'm in conversation with Odeth Richardson. Odeth, feel free to introduce yourself.
Hi, good afternoon, everyone. My name is Odeth Richardson. I am Head of Service for Occupational Therapy within the northeast of England in a large teaching hospital called Newcastle Hospitals, and I am also Chair of Council for the Royal College of Occupational Therapists.
Well, we're absolutely delighted to, undertake this recording for Temple University College of Public Health, a part of a collaboration, a conversation about international perspectives in occupational therapy, education and training and practice. So thank you, Odeth, and thank you for colleagues at Temple University. So question number one, Odeth, what inspired you to become an occupational therapist? Why did you decide to choose OT all those years ago? What attracted you to the profession?
So I've always been attracted to a career in healthcare, and initially I thought I was going to train to become a nurse. And then one day I went into the hospital and I went onto one of the neurology wards and I came across occupational therapists. I was really intrigued in terms of some of the stuff they were doing. And I thought, that's an occupation for me. So I researched it and I realized the impact that occupational therapy has on people's lives. So I decided to pursue a career in occupational therapy.
Yes, we definitely all have a journey. And today, if you had to meet a layperson, a stranger, um, how would you, sell occupational therapy? What would be the elevator pitch? How would you describe what occupational therapy is?
Well, I would describe occupational therapy as supporting individuals to live their lives their way, regardless of physical, psychological, or any other impairments that they may have. So, as occupational therapists, we would provide techniques, advice, support, guidance, and tools to enable individuals to function effectively whilst they undertake their daily tasks.
Oh, thank you. Well, relate that then to, your experience now. You work in the north of England. Um, just, you know, describe how you think members of the public in the north of England and the Newcastle region perceive occupational therapy.
So, as you say, I'm located in the northeast of England. It's one of the most deprived areas in the UK. So within our geographical region, we cover a population of approximately 3.2 million people. Our region is comprised of three clinical care groups. So that is Northumberland, North Tyneside, and Newcastle Gateshead. There are three foundation hospital trusts situated within our region. These are Northumbria Hospitals, Newcastle Hospitals, and Gateshead. Our region also covers four council areas. This is North Tyneside, Northumberland, Newcastle, and Gateshead. So within our region, we had two different systems operating. We effectively cover the local population as a district general hospital in each area with smaller satellite health centers. But we also have our specialist centers, which are regional services for areas like burns and plastics, pediatric services, cancer services, neurology and neurosurgery, transplant, and cardiology. So in general, OT is perceived as being necessary to facilitate safe discharges as well as supporting people to remain safely at home and to avoid hospital admissions. In our specialist areas, OTs is perceived as necessary and crucial to access services that are necessary to support varying conditions. For example, within pediatrics, OT is seen as necessary to open the doors for children who have sensory, neurodiverse, or physical needs.
This is amazing. You know, it's like a totally comprehensive service by and large, which doesn't require health insurance. Um, tell us about the historical context then about, how health is provided in Britain?
So we're very lucky in the UK in that our healthcare is delivered by what we call the NHS Constitution. So the National Health Service, it was found quite a number of years ago with the passing of the National Health Service Act in 1946. So the essence of this legislation or Act of Parliament was the provision of free healthcare paid for by national insurance contributions deducted from the pay of every working citizen. The main mantra for this legislation was that healthcare would be universal, that is, free at the point of delivery from the cradle to the grave. The fundamental principles being that you could have a healthy population, you could have a population fit enough to work and build an economy. We understand today that it is there to improve our health and well-being, and it's supporting us to keep mentally and physically well, to get better when we're ill, and when we cannot fully recover, to stay as active and well as we can to the end of our lives. All of this is underpinned by the NHS Constitution. The NHS Constitution has 7 key principles, and these are: first, the NHS provides a comprehensive service and is available to all. Secondly, the NHS, access to the NHS is based on clinical need, not on your ability to pay. Thirdly, the NHS aspires to the highest standards of excellence and professionalism. Fourthly, the patient will be at the heart of everything the NHS does. Fifthly, the NHS works across organizational boundaries. Sixth, the NHS is committed to providing best value for taxpayers' money. And finally, the NHS is accountable to the public, to the communities, and the patients that it serves. So all of these areas are very important to us as part of the NHS. And if you speak to anyone in the UK, they are very proud that we do have the institution of the NHS.
One thing's for sure, in terms of from my experience and how I've understood how it's organized, you can have a typical hospital in a community that has a casualty or an accident and emergency department. And we call those trusts or National Health Service trusts. And there might be a range of specialism in that building. But maybe a few miles away, there might be a building dedicated to people with psychiatric or mental health needs. So, that's sort of a mental health trust. That the ambulance services that respond to emergency services, they sit in another organization called an ambulance trust, and there's a focused organization on how they deploy and how they respond to people. And then we got probably, this is an interesting one, community providers. So another sort of organization which might employ district nurses, community physiotherapists, dietitians, equipment services, for example. And it's quite fascinating, isn't it, how these division of labor set out there throughout society comes together in a comprehensive and responsive way. Any thoughts, any reflections, are there?
They certainly do. And not forgetting our GP practices. So that's our general practitioners. And they're sort of the linchpin. Again, they're sort of the access to all of these services on behalf of the NHS. So if someone is ill, they would go to their doctor. The doctor would refer them on to other services, whether that be mental health trust, ambulance trust, acute trust, and so on. If somebody is ill in an emergency, they still have direct access to our emergency departments, which is fundamental in terms of making sure that access is accessible and quick and rapid and there at the point that it is needed. So all of these services coming together to provide healthcare for our population, it all, as you say, comes together and it all works to support our population.
Thank you. Can you describe the healthcare delivery system here in Britain, especially in relation to occupational therapy services?
Now that's an interesting one. So within the UK, occupational therapists are either employed by the two largest public sector providers. So these are the hospitals and the community-based services. So the hospitals operate under the National Health Service banner, and then social care operates as part of our community-based services under the banner for local government, so our council providers. So the typical care arrangements means that inpatients are treated by NHS occupational therapists, and people living in the community can access social service occupational therapists. So these are by large the two largest employers that we have providing occupational therapy. However, we also have occupational therapists who work in other areas of the profession, so that we have occupational therapists in independent practice, in things like mental health, in learning disabilities, and so on. So there are other areas where occupational therapists practice. However, the largest ones are within the NHS or within social care. So from an occupational therapy perspective, healthcare is delivered by individual organizations in order to address the needs of their local populations. So where occupational therapists are employed by hospitals, often they're part of a wider group of allied health professions, such as speech and language therapists, physiotherapists, dietitians, radiographers, etc. And their remit, the main remit of hospital employed occupational therapists, is to provide rehabilitation, therapy, to facilitate discharges, and to prevent admissions to hospital. From a social services point of view, they also employ their own therapists to help them deliver their statutory duties. These therapists mainly undertake housing and environmental adaptations, moving and handling risk assessment to support clients to maintain their independence at home. They operate under specific statutory duties signified by the Act of Parliament called the Care Act, which was instituted in 2014. They're also obliged to maintain services under the Health and Safety at Work Act, which was implemented in 1974, the Manual Handling Operations Regulations in 1992, and the Housing Act in 1996. These are just a few. And so individuals can seek recourse in the law courts if the provision of services falls short of what is expected by law. So generally, timely delivery of services fulfill the statutory, often benchmark obligations for occupational therapists who are practicing within these areas. Service innovations also mean that occupational therapists develop emerging scope of work in the following areas. So in GP surgeries, in prison services, within learning disability services, in mental health services, in charities, for example, in hospices, and in independent practice. Within each of these areas, posts are funded from the organization's identified budgets, except for occupational therapists in private practice who can charge a direct fee to the client or sponsor.
Wow, that really is nicely webbed, integrated services, and we have, ICBs. These are boards now that continue to oversee the needs of its local population. One thing I'm familiar with is that local authorities, they have a joint strategic needs assessment, a published 4-year record or plan of all the needs of their local population. No one gets excluded. So whether you're someone born with a condition, a congenital abnormality, or somebody who suffers with a stroke or type 2 diabetes, there's almost, it's really comforting to know, in a sense, that the councils, in partnership with health, track the public health needs of the population. And we're fully aware, for example, at this time, that life expectancy for men is a little bit shorter than women. Between 2018 and 2020, the average life expectancy for men in England is 79.3 years. The average life expectancy for a woman in that same time period is, 83.1 years. The UK population is projected to increase by 3.2% from an estimated 67.1 million in the mid-2020s to 69.2 million by the mid-2030s. And services have to adjust, whether it's efforts to increase the number of doctors that are trained, efforts to increase the number of nurses that are recruited. The UK population growth over the next 10 years is projected to be driven by a net of 2.2 million people probably migrating into this country. And from an optimistic standpoint, much of those are skilled workers that join the care sector. We're forever grateful as a nation that that's the case. We were always told that, from the, mid to late 20th century, that we're an aging population.
Yeah.
Technology, medication, keeping our populations older. But even there's an increasing number of older people. The number of people aged 85 plus is estimated to be 1.7 million in 2020, which is 2.5% of the population in the UK. And this projected to almost double to 3.1 million by 2045. When you hear those sorts of numbers, I always valued what older people have done for society and what they do. And I think that's truly the caring side of us, isn't it? The vocation, but what in the business, what does that really mean when they talk about aging population and older people? What do you think that really means on the ground?
It's an interesting one, isn't it? Because we know the population is growing, is getting older, but we also know that occupational therapists do have a vital role to play in supporting these populations as they age. Unfortunately, within the UK, we do have a shortage of occupational therapists. We're not training enough. We've been outside of the UK to recruit internationally. But even with those figures coming in, there's still a significant shortage. So we need to do something really radically different over the next few years in order to meet the population needs. And I think within the UK, we've just completed our first workforce strategy, and that's given us some figures that we're about to interrogate and have a look at to see how we can actually meet the needs of those shortfalls, because it's really important that we're able to do that with this aging population that we've got.
Yes, and that's the hope for the future. But on a day-to-day basis, there's still bottom line business. And so in that respect, how does medical infrastructure here in Britain support and challenge the delivery of occupational therapy services?
So I think within the UK, the medical infrastructure both support and challenge the delivery of OT services. It helps in the following way. So for example, the system enables individual organizations to fund elements of occupational therapy. For example, hospital-based OTs are funded to support effective, safe discharges, but also to provide therapy, to prevent deterioration of certain conditions, and also to enhance the people's quality of life. Rehabilitation plays a great part in terms of what occupational therapists are funded to do within the NHS. Within the social care sector, OTs are funded to support staff and clients to discharge their statutory duties. So they predominantly undertake assessments on behalf of the local authority to ensure that clients can maintain a level of independence and remain safely at home. This reduces the burden of care being provided by institutions. Rather, they're supported to remain at home, often with domiciliary care packages, and they're assessed and reviewed by social workers who are also employed by social services teams. Some challenges include organizations not valuing the contributions that occupational therapy can make to their patients and therefore not investing in the profession. It is sometimes difficult for OTs to justify their worth, and so without robust evidence, their value is sometimes overlooked.
Yes, sometimes we do complain, we say, wow, that person is a social prescriber. That should be an OT doing that role. Or that person is a personal independent payment assessor. They have a nursing background. An occupational therapist should be in that role. Let's just talk about role emerging opportunities that come our way and that go out to other new semi-professionals. Is it something that we should be worried about, or do you think it's just at the end of the day, what matters is the needs of that person and how they can be met by the most trained, affordable, and skilled person to do the job. Any thoughts, any reflection?
I think sometimes roles blur, especially when it comes to our MDT colleagues and other therapy colleagues, because sometimes the training is quite similar in aspects, and at other times it's very different. And so, from an occupational therapy point of view, sometimes we're in danger of losing some of that niche element of our role because we're so skilled in so many different areas that we sometimes need to sort of maintain that core of occupations and being able to enable people to do the things that they want to do. And if we lose sight of that, we're often at risk of other professions stepping into that gap and sort of taking hold of our core ability to do things like activity analysis to make sure that we have the patient at the heart of everything we do and use all the skills that we have as occupational therapists. But there are times when the patient is best served by collaboration within an MDT forum. Each member of the MDT will bring different skills to the table. And so that collective group will also help to enhance the patient's care. And so we need to be sort of sensible and collaborative enough to know that if we have the patient at the heart of everything we do, then there are times when we'll need to work together to get the best care for our patients.
In the moment, I'm going to ask you to focus on OT experiences and perceptions. But I'm really appreciative of the nuance, the dilemmas, and the sense that we've still got to remain focused on being or providing well-trained occupational therapists, adhering to the Royal College of Occupational Therapy standards of professional conduct, the Healthcare Professions Council, the other regulator. And so these are fundamental standpoints that can still hold us in good stead. But when we think about, occupational therapy experiences and perception, do you think, disability is perceived in a progressive way in this country?
In some areas, I could say yes, but in other areas, there is still some residual stigma attached to disability in the UK. So within the working environment, you find that staff are very reluctant to declare their disability status because some staff feel that this would be used against them in some areas. The NHS is seen as a disability confident employer and employs people from with a range of disabilities, yet staff don't feel confident discussing their challenges. So for disabled patients and clients requiring a service of intervention, there are opportunities to receive support. However, some people still struggle with accessing the available support. And so there's a mismatch really. Often physical disabilities, when you can see the disabilities, it's people will accept it or they will understand why the person has a disability. The hidden disabilities, so for example, mental health conditions and some of those hidden disabilities that you can't see, they're more difficult to accept because people assume that because you look okay, then that you're okay. And so those ones are really challenging.
Well, how do the following support limit access for persons with disabilities? And, for example, the built environment. Years ago, we had the Disability Discrimination Act, for example. I can't remember if it's still active or if it's been superseded by the Equality Act 2010. But tell us about things like the built environment
Yes,
policy,
so some of the
education.
built environment in terms of the property, most of the properties were built years ago when accessing the environment was not really thought about. It didn't occur to people that, environment should be accessible. So this includes mainly homes built, but also some of our public buildings. They'll have lots of steps going up to them. There'll be no lifts in some of the older buildings. But we've come a long way in terms of the modern properties that are now being built. They're built with access in mind, so it's less of an environmental hazard. But with our older properties, with things like your steps, your stairs, your entrances, steep gradients, There's been the development of apps in recent years. For example, there's an app called Disabled Go, which supports a disabled person to navigate public spaces by highlighting where the accessible entrances and facilities are so that people can plan their journeys ahead. There's a big push from central government as well in terms of policies, and policies are in place to support the experience of disabled people. For example, the Disabled Facilities Grant. This is a grant that it can be accessed by disabled people to support them in making their environments accessible. The challenge occurs when there's a local interpretation in terms of how this is applied. This can sometimes lead to inconsistencies, which can then lead to limited access for some people. And then we also have to throw into the mix things like education. So education is often available to everyone, but people who are neurodiverse are sometimes diagnosed later on in life, and so this could impact on their ability to learn. We find that dyslexia is not routinely diagnosed, and so people will often struggle in silence until they're diagnosed years later, and these can also impact on one's education attainment. With appropriate help and diagnosis, education can be a good leveler. And then we think about the culture. So previously, people with disabilities have been hidden away by families as families were embarrassed. This culture has now changed, and people with a disability are starting to be celebrated. We now have visible role models on television and in the media, and this has helped to change the culture somewhat.
This is really the thing that gives me a sense of optimism and hope that we are truly a liberal and progressive society and inclusive. Earlier on, you mentioned about parts of the north of England being some of the most deprived in Britain, and we have a range of indices that measure deprivation, such as high unemployment, such as the number of young people that are not in education, employment, and training after leaving school. We also have, if you like, legacy from the change and shift in industries.
Mhm.
With that in mind, can you tell us about the experiences then of delivering occupational therapy services in the northeast of England?
So within the Northeast, as you mentioned previously, we have the legacy of the mining industry. So it was it's a very industrial area of the country. And so occupational therapy is delivered to keep our patients safe and well at home and also to prevent hospital admission. So occupational therapists will provide assessments, training, equipment, and education to ensure patients are safe when they return home. However, we have some waiting lists within our adult areas of our community-based teams due to a shortage of occupational therapists. Within our pediatric services, we have a long waiting list as the demands outstrips our ability to provide the appropriate interventions, due in part to reduced staffing level with specialist skills and knowledge, as well as experiential knowledge in the number of children requiring OT. So in order to help address this, we offer a three-tier model using the framework of universal, targeted, and specialist. So this framework focuses on four key principles. The first one is to ensure that resources are used wisely. The second one, to ensure that we extend the professional's reach, ensuring the maximum number of children can benefit from occupational therapy. We also build capacity among others to identify and support our children and young people with the SEND and understand when to refer on for more specialist intervention. And SEND in this case means the special educational needs of those children. And finally, it prevents problems from escalating and ensure that fewer children require specialist service and that children with more complex needs can access occupational therapy in a timely way.
I
So within
remember,
our,
I'm
oh,
sorry.
go ahead.
Yeah,
So within
remember
our
this.
universal model break, I'm just going to explain a little bit. Within the universal model, those that we provide information, advice, guidance, and support, and these are given to all children. And those who require more specialist advice are given the specialist assessments and intervention.
Yes, one of the things, thank you, I recall from this, I think it was when the 2010 coalition government came in, And this was a time considered that where a lot of cuts had to be made. I think over 4 years, the common message was services had to provide double the amount of outputs for something like half the budget. They had to demonstrate savings on a year-on-year basis. And this idea of capacity building really came about, the way in which partnerships had to be forged with all the sectors, the NHS, the third sector, the charity, and social services. You know, do you remember that moment, those times?
Yes.
And tell us then about, you know, how best practices were still achieved, perhaps during that time.
So I think best practice, we had to sort of utilize all the skills that we have at our disposal in terms of within our arsenal. And although there were challenges in terms of service delivery and a number of therapists available, we had to try and deliver services very differently in terms of how we intervene with our patients and our clients. And so because our services are benchmarked against other services within the UK nationally, we use this benchmarking framework, and we have something called the Model Hospital Framework, where we use that. We have a peer review services. We have all our services being inspected by the government's Regulatory Care Quality Commission body. And so we also rely quite heavily on research, because without research, we can't impact our intervention. So evidence-based practice is quite key, and we would regularly change our interventions based on the best available evidence. And so we use that to support our interventions alongside our RCOT's evidence-based practice guidelines, which are often developed according to the challenges that staff face, the interventions that are relevant within a particular area of the service, and so on. And they're also in response to government targets and agendas as well.
Do you think that when much of our generic services or specialist services provide, you know, evidence-based practice, do you think our standardized assessments really come to the fore? And are there examples that, you know, that you're familiar with, that you've seen really kind of appreciated at the front line of NHS health and social care?
So within occupational therapy within this region, we do use a number of standardized and non-standardized assessments. So for example, we use the CMOP, we use the TOMS, the Baileys, we use the COWA model, we use MOCA, and so on. But recently we're coming to the realization that some of our assessments and our models are quite Eurocentric, and they're centered within the realms of colonialism. And so the cultural aspects of our very diverse population that we have now is not necessarily being captured. And some of our tools aren't as effective as capturing those cultural elements. So we still have some work to do to try and ensure that our assessments are culturally relevant and that they can be used in different contexts. We also use a number of various different instruments and so on for intervention. So for example, we have things like reminiscence therapy, we have breakfast groups, we use sensory integration, and all of those techniques that are important and unique to occupational therapists, we utilize them as part of our practice.
It's interesting that, because technology moves at a pace, and there's a saying, one step forward, two step backward, moves at a pace. And if our practices are not truly appreciative of our, say, our multicultural society, then we have to go sort of back and forth. We have many regions where over 100 languages are spoken in communities, because of that diverse society, with people originating from different parts and different parts of the world across the globe, makes it really rich and fascinating. But I want to move on to sort of carers, you know, because often people from those cultures have a rich care network that often it's not visible to our eye, that commitment shown. But how involved are caregivers in the occupational therapy process? in your region, and what impact does this have on occupational therapy outcome?
So within this region, some of the patients' culture, um, it's really important to bear that in mind when you're doing any sort of OT intervention. And this culture can contribute significantly to how much or how little our caregivers contribute to the therapy process. So, for example, in some cultures, the family are more involved and are invested in ensuring the best outcome for their family members. In others, there's just a minimal support and there's less intervention with families. So, in situations where there is involvement, this can support patients to recover better, as therapy is often practiced at home once they're discharged. In families with less intervention, this ability to practice is diminished and the outcomes are reduced. And so it's really important that if we can get that engagement in terms of the OT process and so on within our patients and with their families, that it's always easier and it's more impactful.
I'm interested to know about some of the third sector work you do in Newcastle. We're talking about every year, sometimes I see on social media, you champion the good work of Women to Win or Women of Culture in Newcastle, who do a lot of work in the third sector. Can you give examples of some of those networks that you have helped to form alliances with, and some of the work you do outside of your day job?
So I do a few bits outside of my day job. So one of the things I do as part of my voluntary role, I volunteer for a charity called the Angelou Centre within the northeast of England. So this is a Black feminist organization that supports women and girls who are suffering from domestic abuse and violence. And so within this forum, we provide refuges for these women who are fleeing those situations. These women often have no recourse to public funds, and so the Angelou Centre provides a framework. So we provide the support. Often English is not their first language, and so we provide things like English as a second language. We do offer training courses. We ensure that when the women leave us, they are able to forge a new life. So they're taught skills like dressmaking, baking, cooking, and all of those things that will support them and enable them to make a new start, really. In addition to that bit, I do a little bit of work with Northumbria Police as part of the Strategic Independent Advisory Group. And so in this role, I call myself a critical friend because often our police services don't always get it right in terms of their policies and processes. And so we're there to provide advice and guidance on their policies and their processes and some of their stop and search opportunities to sort of intervene and say, well, actually, we review those cameras. Maybe if your staff did this or they did that, or if they did it this other way, then you might get more engagement from the communities and so on. So lots to keep me busy within the Northeast in addition to my paid role, which I do enjoy the variety.
Thank you. I'm interested in cultural considerations and global perspectives. It's just amazing. All those sectors that you have a link with. You know, if an American trained occupational therapist came here to work in Britain, you know, what would you like them to know?
Well, first of all, I would like them to know about our NHS constitution because that's slightly different to how they work within the United States in terms of the OT context. And I would also like them to know how important that is to us as a population. I would also invite them to sort of understand a little bit about the regional variations in services and how the postcode lottery can impact on people's quality of life. I would encourage them to be open to learning new ways of delivering OT and would encourage them to get involved in local cultures around them so they can better understand how to support their clients and patients effectively.
Thank you. In your perspective, then, what are some of the things clinicians should keep in mind as they aspire to work as global citizens?
I think clinicians need to be mindful that they need to be culturally competent in order to meet the needs and the challenges of a diverse population and as global citizens. As occupational therapists, we are trained by a white colonial lens. Therefore, the onus is on us to ensure we get a more global perspective. Our standardized assessment, as I mentioned earlier, are standardized for one element of the population. And of course, we know one size does not fit all. So OT should be mindful of ensuring that their therapy is person-centered and that the occupations they are proposing has meaning to the client.
This is great. I shouldn't get emotional, but I'm really enthused, but you know, by what you're sharing. So how do we keep a global perspective?
I think we keep a global perspective by being willing to learn, but also willing to unlearn some of the things that we've been taught. So by understanding the historical context in which we all work, by exploring different cultures, and by trying to understand how their histories impact on them today. By immersing oneself in local cultures whilst on holidays, etc. Because some of us are quite safe in that we will go on holidays, but we'll go to a resort where it's safe and you're sort of contained. And we don't go off the beaten track to sort of explore some of the culture and to see how people live their lives. And I think as occupational therapists, we're all different in terms of personalities, but that's something that we should perhaps try to do when we go to a new place, to try and embrace some of the cultures, to try and understand from a local perspective how those cultures impact on them, especially from an occupational point of view.
Okay, so how do we enhance cultural humility then?
I think by enhancing cultural and worldview, by seeking to understand different cultures and different worldviews, we can do that by also maintaining curiosity, because curiosity is a good learner. In terms of becoming curious towards cultural differences, we also need to remain humble and being willing to learn. As therapists, we need to be able to incorporate this knowledge of various different cultures and respect for other cultures, behaviors, belief systems, and worldviews in our practices. Because other individuals from backgrounds separate to our own, they live their lives differently. And in order to deliver high quality, effective, safe, patient, and family centered care, it is essential that our care is evidence based and that it is equitable and that we're delivering it diversely to a diverse population.
Thank you, that's great. So based on what you know about OT around the world, how do you think your perceptions of OT compare with others?
I think our perception of OT within the UK context is based on white Eurocentric lens. So, from a personal point of view, my culture is really important to me. And so I always try to incorporate a patient's culture in any intervention. In other cultures around the world, OT is viewed through many different lenses, and an understanding of these is vital. Around the world, OT training is centered around the lens used by the founders of the profession and remains deeply rooted in colonialism. The onus is on us to ensure that we use some of our experiences, that we always maintain appropriate professional boundaries by ensuring that the patient is always at the heart of everything we do and that we are intervening or giving them intervention based on the things that they want to do and the way they would do it within their individual cultures.
I think this is quite poignant, and we often ask our students to um, articulate cultural humility, cultural competency from a critical perspective. And one thing I've tried to encourage them to do is ask, can this help us to practice in anti-racist ways? I think, is it okay to have a conversation that speaks to that, Odette?
Yeah, I think so. And I think from an occupational therapy point of view, nobody really sets out to be racist, but our structures and our processes and the policies within which we work, they help to enhance this attitude of racism because people don't always understand what's different. And sometimes difference scares people. And because others are different and it's not something they're used to, you run the risk of running alongside the policies and the procedures and all those processes that we work under, that you can become racist. And so it's really the onus is on us to become actively anti-racist, to support our colleagues and others around us to be able to look at things through a different lens and putting ourselves in the place of the other people on the receiving end of it. And so when we see behaviors that are not as we would want them to be, the onus is on us to try to educate people, to support them, to help them to unlearn some of the things that they've learned over the years, and to show them that there are differences and that we need to celebrate those differences and work together for the betterment of everyone that we come in contact with.
Odeth Richardson, Chair of Council, Head OT, Newcastle Hospital NHS Trust. It's been an absolute pleasure meeting, talking to you today. And I'm sure that the listening audience will truly appreciate the conversation and discussion and the content of this material. I'd like to wish you all the very best. Thank you very much.
Thank you, Blaine. It was a pleasure. Thank you.